you a little bit of background about this group. Essentially, we've set up a group at Wits University that is really about trying to get some focus on primary health care and the way in which we could strengthen primary health care within the context of NHI. And in doing that, we hope we can organize it for researchers, particularly. And in this process, we said, how do we actually go about this process? After a discussion with some of the researchers, we said that I've been managing, that's PhDs, a few of them, about 4 PhDs, and others, we said, let's form a research group. It was also an initiative from the Department of Family Medicine in Wits to say, please, let's set up, some senior researchers set up some research groups so that you can do it. So this is the research group. Unfortunately, I couldn't set it up within the Wits environment, but it's there on my personal website. And you can see that the idea is, let's have an open webinar, with 1 to 2 p.m. And then let's see if people are interested to build up from there. But then we also have a closed meeting after this, which is really to work with researchers that are interested in the researchers. We hope the open webinar will stir them up. So we're looking at finding people both in South Africa, Africa, and worldwide to see if they can add insight into how to look at primary health care within the national health insurance space. Given the fact that we're talking to South Africa and they're not from South Africa, but we'll see how to do that. So some of the discussion is to strengthen that. The research meeting itself, and I'm really there to try and inform you about it, is masters, PhDs and masters. We also are very interested in having senior researchers as well as officials with research interest, and then potential researchers. And we'd like to help potential researchers to sort of take up issues as well as senior researchers. So there's a PhD research and a master research concept note that we put out here, and we'd like to support that process. We've got videos on the Afro-PHC website, and we'd like to actually encourage you to do that. It's still open nonetheless, so please feel free to fill in the form and join us if you feel you'd like to both set up on a particular path of research, or if you're willing to supervise. So we'd really be quite happy to support that. But that's the closed meeting, so please let us know through the form, and the form is basically on the Prof Moosa website. NHI research. There are other things there that will give you under the NHI some more information on developments, including bills, etc. And we'll populate that as well as what's happening within the Johannesburg space. Again, we'll open that up or provide more information as we're going along. So I don't have any questions, but feel free to raise them in the group. That's just a quick promotion. The first webinar that we've set out to do was to share a little bit about the NHI, and I basically put together a presentation. So for those who are new to South Africa, I'm actually going to talk a little bit about that and give you some information, but we'll also then be digging into sort of some relative technical detail about what the bill says and try to also reference what's happening in other parts of the world that could help us inform this process. So let me start. So the focus today is looking at the NHI Bill, which is a second iteration of the bill tabled to Parliament, and looking at it with a focus on primary health care and some of the changes to it, relevance to primary health care and its implications. I'll talk to more of the perhaps later as we're going along for those who are not familiar. But I think that South Africa, firstly, I think there are many people who are not from South Africa, seemingly on the webinar. So in South Africa, we have 60 odd million people. We have about 10,000 generalist doctors, but it's a mostly nurse-provided system, which I'll talk to, excuse me. So it's spread between the public and private, and a lot of the challenge from 1994 was trying to build up improvement from the post-apartheid era, where there was really very limited access to the post-apartheid era, and now to actually expand that further, and what that means. So I think that for the current attempts at universal coverage, the National Health Insurance is in fact a vehicle primarily for funding, financing, and it is not everything about UHC. But I think it's a very important change in our system around the financing of healthcare. I think all of us understand the dimensions of primary health care, which is the population covered completely with as little cost as possibly, with as many services and quality services as that. And I think there's no country with nothing, and there's no country with everything. So it's really a journey of improvement. Within the South African context, we have basically got a public service, which is where from 1994, with our constitution and being sort of something of a negotiated arrangement in the apartheid transition, post-apartheid transition, that there was a lot of federalism incorporated into it, and the monies were transferred to the provinces to implement health. So all our system at a national level is policy planning. The provinces are the essential implementers. And then on top of that, over time, was both the district health service system as our local government emerged. But in 1994, in fact, in the 1980s, later 1980s, the apartheid regime realized that, in fact, we are going to move along and embrace a democratic South Africa. And the privilege of apartheid was in the way of access, access by the white community into public hospitals for them were going to shift and change, like public hospitals and the specialists associated. And so there was a deliberate attempt in the late 80s to privatize or deregulate the private sector and allow a number of hospitals to emerge. The medical scheme became much more looser, much more available. And in fact, unions chased that as an important piece of the remuneration. So from the 1990s, with that impulse from the apartheid regime, the 1990s saw a big burgeoning of the private sector, with a lot of the specialists moving from public hospitals into these private hospitals that were also burgeoning. In that same time, the government basically set out with these 9 provinces that were much more federally funded to then set up a health system. And we were very fortunate in having many local government clinics that were spread out, much more available to the population. And there were nurse clinicians that were trained in the apartheid years that allowed us to create a nurse-based primary health care system that supported the district health service. And so this became the key tool for shifting universal coverage across the country, making it free to access as much of the population as possible, which grew progressively by more clinics being built. And the services were obviously limited by the capacity of the clinician nurse. These were upgraded slowly to add more services and training over time, but also the doctor availability was something of a sort of initially not available, then visits, and now moving to much more full-time doctors. So I think that's been the nature of public health services. But as time has moved on, the public service delivery, in contrast to the very expanding private sector, which has grown much more exponentially to the public service, has been a very strong contrast to the majority of the population. So 15% are covered in private sector funding. A fair number of people actually use the public-private sector for out-of-pocket, but the public pool services 85% of the population, and that's how our public service, our overall health is moving along. Government has contributed about 15% of total health 15% of total budget is the total health expenditure. So it's really substantially high by global comparisons. But about when you look at the total percent spend to GDP, it's 8.5%, but almost half of it is being spent in the private sector for that 15%, whereas the other half is being spent in the public service. Well, the dynamics around these are, something that, lots of argument happening. You're taking away, you're privatizing or nationalizing the private sector, etc. But I think we need to look at the legislation to understand it. And for researchers, it's really important to understand these dynamics better. So looking at the government plan is to look at all these very fragmented pools of funding, 9 provinces, but also other sort of smaller funds like the Occupational Health Disease Road Accident Fund, and pool them together with some of the contributions to medical scheme credits, etc., that would be covered, and then pool that into one national fund together with taxing that would be probably progressive, and that would impact somehow on the private pool, because at the moment the private pools are very fragmented in themselves. And I think government in time wants to try and reduce these pools, especially the perversity of care. But question mark about whether you can totally remove medical aid as a private pooling over time, or whether you can manage that through other mechanisms. Nonetheless, that's the overall principle, is to have a single pool of funding with single purchaser. So that's the purpose of the NHI, and importantly, it's to try and bring the private sector, and I think particularly bring the private providers, which are not only the specialists, but also general practitioners, back into the public service in the overall public mandate, but not necessarily as employees, but as contracted in. And also to shift the strategic purchasing to actually contract more directly with the frontline public care provider. So this is some of the impulse within the reforms to find a value equation somewhere in between. So looking at these introductory slides, it helps you to sort of get an overall big picture before we dive into the NHI Bill and exactly what the changes have been, what it overall says overall, what it says particularly about PHC and the changes, and then what are the implications. Well, the population at the moment contributes to medical schemes out of pocket in the proportions, and essentially they contribute to the fiscus, to medical schemes who then pay general practitioners, and predominantly a fee-for-service payment system, which is also the same with out-of-pocket expenditure to those same private providers scattered quite a lot in central sort of middle-income areas, higher income areas in South Africa. And so there's a lack of these particular practitioners in some of the less resourced communities of South Africa. The population also contributes towards tax, which goes to the national treasury. And in our federalized system, that fund is mostly flowing to the provinces. And at the moment, because the provinces are the principal agents, they have got a district health system, but not all of the funding is actually distributed down to that level, and even less is distributed down to the sub-district community health center and clinics, which are the principal vehicles for public service delivery. You get some local government clinics that are being funded partly, and non-state actors also that are running clinics that are being partly funded from the district. But you'll find a community health center who has a budget of, $5 million or 100 million rands. And if you ask her how much do I actually have to spend, she'd say 5,000 a month is what I really can spend. The rest I'm going to send requisitions up here, there, and it sort of goes up the levels before permission comes through. So if there was a family physician that needed to be approved for the sub-district, that would probably have to get a provincial approval. And so it goes on. So a lot of the district permissions have to go to province and sub-district to district, etc. So it's a very bureaucratic, and it's funded through a line item budget system. So this is very non-responsive.
Shabir, you've hit the mute button for some reason. We can't hear you. Shabir, you need to unmute.
Sorry, I don't know why that happened, but thanks. Maybe somebody else muted me, but no problem. Let me just get back to that. When did I stop, Steve?
About 30 seconds ago.
All right, so it's not too much. Okay, so so essentially the funding is now moving to a central fund, which is a Section 32A organization. So it's a state entity, not a commercial organization, but rather a independent organization with a board, CEO, etc., that is going to manage a very narrow mandate of transferring funds in a purchasing agreement between various providers. What it does is allow funds to flow through contracting directly to hospitals, to sub-districts, which are very much more decentralized. So the full amount will kind of circumvent province and district to reach a sub-district. And it is basically going to also allow the NHI to contract with a whole lot of the private providers if they should embrace the system in a capitation for primary health care. There is a plan to manage hospitals with an initial budget and then slowly diagnostic related groups. But in primary care, it's a predominantly capitation system. There's inevitably going to be elements of line item, fee for service and performance management, but at the moment it's a predominantly capitation system. So essentially this is the terrain, and there's a lot of questions being asked, but this is foundational legislation that's being put together. So the expectation of enormous detail is in fact challenging, because essential details need to be there, but overly strong detail that might evolve is not good for sort of foundational legislation. So I think that's an important element that all of us need to think about. So this is basically the evolution of the public service. So just to tell you that I'll deal with some of these peculiarities a little bit going forward about the difference of the role of the CUP and the District Health Management Office. As well as so perhaps just to say that, as we've said, and I'll go back to the last slide, in the NHI Bill, it talks about a CUP, and there was a lot of confusion initially, but in fact the CUP as a contracting unit for primary care, and I'll share the details, is now considered part of the National Health Insurance. And the district basically evolving to a District Health Management Office that is now legislated as an organization, formally not a subset of the province, but a distinct organization that will be accountable directly to the National Treasury, with the provinces now acting as agents. So that's really, in principle, what is the way forward. So the District Health Management Office is expected to do what the Health Department is expected to do, which is a lot of coordination, but it says here support, facilitate, support, and coordinate the provision. And that is basically, so the role of the organization is more to support, and whether it remains still a provider of care is still a question. But that's one of the questions that may come up later, is what is its role, but we can talk about that a little later. The contracting unit, now that it's established, is basically a horizontal network that tries to, on behalf of the NHI now, assist the fund, the NHI fund, to actually profile needs, improve access, and facilitate integration, as well as ensure referrals. But it's very likely that with these two bodies, perhaps in the same space, that the CUP lands up just being a very technical support for contracts and its disbursements. But it's left to be seen how that actually pans out. It also is a question how the CUP functions with the DHMO, but also how does the public provider function at the moment. Clearly, the NHI will contract with a various set of providers within the private sector, but the district is currently directly managing the sub-district, and the idea in the NHI is that it will transfer funds directly to that sub-district, which is going to manage funds quite close to them. Whether that provider role is separated from this coordinator role, because that district or DHMO, however it evolves, will have to not only manage at a policy level, program level, these public service providers that are under their current control, but all other providers that are there within that particular sub-district. So it becomes two different animals. One is a provider manager, and the other one is an overall policy program coordinator. So again, questions about how that might pan out. So I'm going to go through the bill. It's highly technical. I'm trying to keep it as trim as possible, but and allow time. So please excuse me. I'm going to try to make sure I go through it. We will also share. We will share the presentation so you can see it on the website. So just looking at this, it's the NHI Bill, which is 2019, which has basically been through our National Assembly, and we have a National Council of Provinces in our parliament, stood by two houses, one representing provinces, and it's currently going through that, and there probably will be more additions and subtractions. So this is the version as of now. So looking at that version, I tried to pick up, what are the key changes? I haven't gone through every detail of change. It's too much of technical detail. And there's most of the changes have actually been the ones that I'm highlighting. So essentially, at a definitional level, the NHI Bill speaks of comprehensive health services, which is really the continuum of service, health promotion to palliative care, the usual. But they've actually added a new definition of basic health services, which seems to be just limited to maintaining good health and preventing serious health problems. It includes preventive services, primary health care, emergency medical service, diagnostic treatment services, and rehabilitation services. So it seems to be reason to change it slightly, and I'll show you why it seems to be changed, apparently in terms of dealing with a particular segment of users that may come along. So the definition also of primary health care is pretty much a standard global one, which speaks of the continuum of promotive, preventive, curative, rehabilitative service, first level of contact, and involving both the public health-owned clinic as well as private sector. The Chapter 1 purpose of the NHI Bill speaks of the establishment of the fund as a single purchaser and single payer, pretty much the same as it's been, with sustainability of funding and the provision of equity and efficiency in the funding by pooling of funds, and importantly, the strategic purchasing. So this is basically key elements, and as I've said, as you're going along, you'll see the changes in yellow, and that would help you to recognize, and I'll make a mention of them. In terms of Chapter 2, access to health, it's essentially SA citizens with permanent resident refugees, inmates, and then those who are traveling will come with, with insurance. But of specific note is that the asylum seeker, and particularly in South Africa, the illegal foreigner, will only be eligible for emergency care, but also notifiable conditions of public health concern. What that care means, it's not clear. So that'll probably have to come out. But it seems that in that element, the bill also talks about all children of legal foreigners will be entitled to that basic health care. Again, needs to be defined, not clear enough in the bill, but probably going to be spelled out in regulation. So registration is that they must provide proof of registration for service, which is in our setting going to be biometrics, given the way the plan is to set up the system that is allocated to a health patient registry number per user, which is the Citizens Plus. So the rights of users to receive quality healthcare service free, it seems in the new bill, in the revised bill, that within the states available resources has been removed, which is a question because, how is that going to be managed? But nonetheless, that's the change. The healthcare service coverage is basically the benefits that are going to be developed as what is available, and that'll become part of the contracting process with more detail later. But central hospitals, which are currently under provinces, will become semi-autonomous, which is very different to their current functioning. They're very much under the will and fancy of provinces, and also part of the National Department of Health, indirectly accountable to them in that sense. Then chapter 3 to 7 of the NHI fund has some very basic elements, essentially setting up this fund as an autonomous public entity as Schedule 3A, my correction, based on the PFMA, which is the Public Finance Management Act, which allows for such an organization to be set up with various functions that are put out there. In chapter 4, there's a board that's set up, and then additionally, they've added that the board should be broadly reflecting the diversity of the Republic. The one appointed, and as well as one appointed by the Ministry of Health. It's a public call with interviews that are very public. The board, now appointment, inquiry, dissolution, and the chairperson require cabinet approval. So you can see that some of the public pressure for stronger cabinet or wider than the minister approval for some of these decisions have kept their way into the bill, the revised bill. The board and the CEO are to meet the Ministry of Health twice a year. The CEO appointment also requires the cabinet approval and is responsible for management, including additionally staff and risk, apart from the usual other management of an organization like this. The units that will be included, there's been one change in that it's not a procurement unit, because the expectation is that this is not about procurement at that level, because it is more about procurement negotiating, it seems, for health products to be available across to all providers. So it's more negotiating prices than procurement as such. Then in terms of board committees, they've been board committees, they've added the question of member conduct and conflicts, and the same with these 3 advisory committees, which are the Benefits Advisory Committee, the Healthcare Benefits Pricing, so Pricing Committee, and then a Stakeholder Advisory Committee. So I'm giving you a sweep of the bill as it stands. In terms of Chapter 8, the NHI funds in Section 31 spells out the role of the Ministry of Health, essentially as governance and stewardship in its role. But Section 32, the role of the National Department, essentially guidance, coordination, planning. And Section 32 then spells out that even though there may be the centralizing of the funds, the ministry, in fact, can delegate provinces as management agents and then establish the district health management offices as government components, which is essentially the districts at the moment, or a revised version of them. Section 33, which is highly contentious in South Africa, given the sort of huge amounts of money in the private sector, is that the role of the medical schemes, once the NHI has been fully implemented, as determined by the minister through regulations in the Gazette, medical schemes may only offer complementary cover to services not reimbursable by the fund. So I think this question is really something in the future, but many people have made that obstruction and contesting it in the legislation. I think even its constitutional challenge will be very limited, given the fact that it's not committing immediately to do anything. So in Section 35(2), the government has changed, the Parliament has changed to say from transferring funds to these, it must reimburse payment directly to various set of providers, including the district hospitals, on a global budget or DRG basis. Similarly, for funds for PHC will be reimbursed directly to the accredited and contracted primary care service providers and health establishment, and no longer to CUPs. So CUPs somehow are becoming agents of the NHI rather than some sort of agent on the ground, sort of managing the funds as an intermediary. I think this is simply because the impetus or the incentive to providers will be very limited with that intermediary. The District Health Management Office, as I mentioned, is now a national government component, which must do all of these things, which is to manage, facilitate, support, and coordinate at the district level. The functions of the NDOH, the National Health Act is also in terms of this legislation being amended. And in fact, this is basically saying the same thing, which is the National Department will coordinate services and not do it through provinces, but not by provinces, but through provinces and district health management office. So it gives National Department of Health a lot more control on the system in terms of accountability at a decentralized level. They've also shifted that to make the deadlock breaking mechanisms to be much more decentralized from a province, which is the executive council of the province, the sort of ministry cabinet at the provincial level, to now be at a district level, which is much more decentralized level, and removing budgets, but actually trying to emphasize the performance targets. So there's some give and take in all of these amendments. The National Health Act also establishes these district health management offices. You can see I'm going to go through very briefly. It's looking at facilitate, coordinate, management of health and human resource plans, managing the functioning, coordinating it, providing disease profiles, improving access, facilitating integration of private and public, receiving and resolving complaints, and cooperating with the investigation units, control the quality, procure, develop, liaise. So the number of these things are actually there. But if you look at it, even with the remnants of the CUP, which is in Chapter 8, the contracting unit for primary care, it establishes it, but it takes away all these elements which I'll go through with you, and in fact just simply says that a CUP is comprised of a district hospital, this horizontal network, as an element of the NHI, it seems. So the contracting unit is supposed to assist the fund to identify healthcare service needs, identify public-private, manage contracts, monitor disbursements, access information, improve access to healthcare, use referral systems, integration, resolving complaints. And you can see there's a lot of overlap between even that and the DHMO functions. So there's going to be some turf wars that need to be clarified, and I suspect that the districts will prevail as we proceed. The establishment of the CUP was actually spelled out in National Health Amendment, but this has been completely removed in the recent change. So all of these functions, which are to be directly contracted by the fund, to transfer funds to them as intermediaries, for them to be responsible population, to identify some of these things like public and private providers, and to sort of get the DHMO to do these on their behalf, have all been taken out. So I think the elements that have been removed, which just simplifies this bill, makes it clearer, but I think there's still more simplification and clarity that needs to come around, hopefully in this iteration. So in terms of other elements of the bill, it basically sets out in Chapter 8 these procurement, accreditation, contracting. So the idea is for there to be centralized procurement in Office of Health Products procurement. And I think many of the times people seem to think that that's actually National Department of Health buying. But the Office of Health Products procurement doesn't buy, it negotiates. The actual purchase happens by providers. At the moment, it's provinces that actually buy these products from the various providers. And so I think people don't have an understanding of how that procurement functions. But nonetheless, that's what it is. Suppliers deliver directly, and then the providers basically provide proof of registration and certification and meet the users' needs of users. They enter a legally binding contract with the fund, and there's a performance expectation. The information platform, at the moment, is the Health Performance Registry System that any provider who comes on board needs to use, both to embark on the registration or enrollment process of any identified user, who is anybody with a biometric that's in the Department of Home Affairs, then has access. And obviously there needs to be submission of other information as one goes along. The payment at the moment is that the accredited provider will be reimbursed directly by the fund, not contracted and remunerated by CUPs, and that it will use a prescribed capitation strategy. And the ministry will obviously make regulations regarding that. There's Chapter 9, which talks about complaints, a whole bundle of issues, what's involved in terms of managing this through an appeal tribunal, both from users and providers. There's also something about the financial matters of the fund, the sources of the fund, which is principally chief sources are tax, medical scheme credits, etc., as is being indicated there, and all of that paid through budget vote in Parliament to the NHI fund with auditing and an annual report according to the PFMA. Then there's a bundle of other things that are put out there, which are the powers of the Ministry of Health, protection of confidential information, offences, penalties, Ministry of Health making regulations regarding all these details and some directives. In section 57, it just spells out these two phases, which have been revised. So you can see that's the change. It's now shifted. The timeline previously was 5 years to last year, and clearly with COVID, that was delayed. Now it's become 3 years to 2026 from now. And in fact, that's a very short deadline to achieve a number of things. And then it's 26 to 28. So you can see that the timeline becomes shorter and are probably quite important to move along. There's certainly a lot of public pressure around the passing of the bill. There's certainly going to be public pressure to implement sooner than later. Chapter 11, even though Dr. Chris says this is a multi-decade process. There's also Chapter 11, which spells out the Section 58, in Section 58, and it actually spells out the question of how the various funds, road accident, occupational health, and correctional services will be managed within that context. So that's the bill. I thought I'd just share quickly, given where we are, that there are some instances that show how organizations, how countries have actually moved along with this contracting and coordination strategy. In New Zealand, with the 5 million people in the 1930s, had free public hospitals, fee for service for private GPs, but very limited with very little funding. And that has actually become even worse. So as of 1986, only 20% of the fee for service that a provider charged a patient was actually covered by government. Most of it came out of the pocket. So that's quite poor universal coverage in New Zealand. So in 1990, they tried to improve that with 4 regional authorities within that 5 million people to set up purchases and negotiate via IPAs, because they seem to be, with the GP predominance in that system, to have capacity, and there was some shift to capitation. And that has been growing, but waiting lists have not really particularly grew. But in 2001, there was a very distinct strategy to, in fact, set out, which said, let's set up 20 district health boards. And if you think about that, that's about 250,000 people who are responsible for planning and running primary health care with these non-profit organizations, primary health care organization called PHOs, which were there to support the relationship between the GPs and the district health board, which were essentially government bodies. And at that time, and it was supposed to involve communities and the providers. So essentially becoming some sort of coordination role because of the lack of coordination previously. And you'll see that essentially these are 2 elements going forward, is the capitation contracting and then coordination. In that, target fee for service quickly evolved to a capitation model and then increasingly performance management at a PHO level. In 2009 to 21, they basically found that they encouraged this integrated coordinated service delivery, but it was really very slow in development. And essentially they found themselves reducing this PHOs and literally made them more alliances between DHBs and PHOs. And in the sense saying that there's a need for much more people power closer to home. So in fact, centralizing seemed to be the solution in that setting to actually building closer service closer to people. So in 2022, they've actually abolished the DHBs as independent purchasers and created one national health system that purchases for all service delivery within the country. They have set up a Maori health authority for particular problems within the Maori community to improve equity, and that's the reforms. But they have set up localities which are smaller than DHB, so decentralized within that very centralized approach of payment, capitation payment. They've set up localities which are very much smaller for planning locally. So if you look at it, you can see this is really the sort of quick input, quick visual on what the newest look of the New Zealand system is. And in fact, localities are dealing with about 65,000 people with these organizations of that locality trying to bring through a number of the sort of various other service providers, as well as interested groups like local government and non-health providers. And I think that's really the question: how do we go forward? And these are some of the questions for our problem as we are looking at this bill. I think England also is a similar challenge, where since 1948 we've had very simple capitation system that's been basically initially for treatment referral and then progressively adding preventive services, and mostly free, but lots of challenges around hospital referrals. In the 1990s, essentially trying to deal with that lack of responsive hospitals is the GPs, which were very acceptable to the population, were tasked to hold funds off hospitals and purchase their referral care. But it became a problem with capacity at that level. And in 1999, they set up these very many primary care trusts to purchase healthcare, public health, hospital care, with the support of GPs, and then look at being involving community care, public health. But again, it had its challenges. It had certainly a problem of leadership. There was still non-harm responsible for hospitals and was seen as just bureaucratic, but it was not all a bad story. It certainly led to the next step of clinical commissioning groups. And I think that the detail helps you to realize that this is not going to be fixed up in one shot. But what you see is a very important trend, that the payment system is very centralized, but the actual coordination is becoming more and more localized. So the clinical commission groups set up to actually purchase these services, referral service from hospitals, and that basically became made up of GP leaders. But I think the problems were that it didn't seem to reflect multidisciplinary team and social determinants of health, which led to the next reform, which was just last year, where a much smaller set of integrated healthcare systems was set up, where the boards, which are much fewer than the 300 odd PCTs that are now boards which contract, whereas they have a broader integrated partnerships, which are even at a very high level comparatively, which are there to support collaboration and competition and bring a principle sort of way in which you bring together the various elements at that level, but also to try and guide these long-term contracts, because a lot of the contracting was very ad hoc and challenging in that setting. So in terms of this, you can see that the NHS England has been through some changes because of these two at a very much more higher level, but you can see that they've created probably more flexibly primary care networks at neighborhood level. So they've created this geographical system, if you look on the left bottom hand corner, which is really a neighborhood of 30 to 50,000, a place with 250 to 500,000 in a system, essentially creating different elements of collaboration and team-based care at that level. And I think this is probably more flexible in our setting and likely to be what we emerge with in the South African setting. So I hope I've not taken too much time and allow more questions, and we'll stretch it a little bit. So let me open up to questions and comments from anybody in the meeting. So,
Shabir,
yes.
This is Karen. Are you aware that your presentation hasn't been presented?
I didn't know that.
None of us have seen, at least I haven't seen any of the pictures that you alluded to.
I'm sorry. I don't know why that happened.
What I would suggest,
I saw them. I haven't been able to see them.
Okay. Good.
My suggestion,
Mustafa, can I suggest you do the video? I think that might be confounding things. Mustafa, Kojali, do you mind just putting a video off? Right. So I think it is available, but nonetheless, I will share it. So
what I would suggest, Shabir, is share the video as well as the recording so that we can watch it again.
Not a problem. I will do that. I've taped it, so it should be available to view. Good.
So we'll all take time to watch it again.
No problem.
Because
no problem. Thanks, Karen.
Sure.
Sorry about that for you, Karen, but we'll share it. Any comments or questions? I know that it's a lot to chew on for people who might not be familiar with the South African setting as well, but it'd really be interesting to see some comments or questions. Go ahead, let's, I think I see Brian and Sharon and then Celeste, thanks.
Shabir.
Yes.
I thought that was really excellent, and I think I haven't read the redrafted bill, but I think what becomes clear from your presentation, and it's I think very welcome, is that the DHMO is becoming more of a supply side entity. In other words, its job is really effectively to manage the providers. That's what it sounds like. The CUP becomes like the NHI regional office. It's like a contracting office. Yeah. It's the entity that's bringing together at a contractual level a whole lot of people trying to work together, and the NHI is then paying people directly. So I think what's happened, if I'm understanding what you're saying correctly, is there's now a much clearer purchaser-provider split, whereas before it was a bit of a fudge. So I thought these changes make a lot of sense, and I think things are a great deal clearer than they were before. So thank you.
No, I think so. You're right. You know that it's clearer than before. I think the purchaser-provider split is there, but the role of the Department of Health between its role as the provider and coordinator is going to be somewhat challenged. So I think at least there's clarity and we're getting somewhere. So thank you. Sharon, go ahead.
Thank you, Shabir. I just didn't understand, and maybe it's not clear. How is a district function a national function? So they have these districts, but they're at the national level, and I just didn't understand what that was. Do you understand? Can you explain?
Well, at the moment, a district is essentially set up in the National Health Act as an organization of the province. So effectively, it is accountable now to the provincial head of department. What this does is it sets up the district as an independent organization with its own, you might say, accounting officer and legal standing, and that is able to then engage in a contracting approach or be able to engage in any way independently. But the head of a district as a district manager will now on paper be accountable to the National Department of Health. So her boss and her PMA is with someone at national. Of course, national will have to figure out. So at the moment, they've indicated in the bill that the national department may give that accountability role back to the provinces as agents. But in the instance that a particular province or a district is non-performing and challenged in any way, I imagine it gives the province and the National Department of Health much more ability legally to in fact step in and take away that agency role and then deal with it in terms of its functionality, etc. I think it's, like I said, you know, a dynamic of increased strength, centralization, but also decentralization. I think you must also remember that there is a project by the presidency called the District Development Model, which is that lots of elements of government are actually being strengthened at a district level, which is decentralized from provinces, to make the government much more responsive with more resources and, you might say, decision-making capabilities, capacity at that local level, and much more aligned to provincial government, so local government. So I think that's the dynamic. I think they're not necessarily, I mean, they're a function, as I say, of the, or accountable. I don't think it's about taking all of them and somehow putting them to sit in National Department of Health. No, they are based in their districts. Thanks, hope that answers your question, Sharon. Celeste? I don't know if there are any other comments, so please feel free to step up and comment if you have any other clarity to add, anyone. Celeste, go ahead.
Hi, I'm Celeste. I'm from Wits. Thank you for the great presentation. we were thinking of looking at the health benefits package, and I was just wondering if the NHI has any work towards that, or how is it proposed that, I mean, you've explained really well how it's all going to be financed, but how are we going to propose to choose which services are going to be financed in the community?
Yeah, I think that and that there is work being done. I'm not privy to details, but in our discussions at a local level, we've said, and I do play a role as a lead project manager, so be careful sharing things but these are things we're sharing broadly anyway, so it's fine. So essentially, the package that is the benefit will basically be something that will be funded through the NHI. So you're going to decide what is it that I can or should provide, and how much is it going to cost, and can we afford it? So it's really that kind of dynamic, and also looking at the pricing in the public and the private sector and all that. So there's going to be many challenges for many elements, I think, of the overall health system to get quickly at sort of negotiated pricing with, let's say, a neurologist for all the services they could provide, a fee, or maybe hospitals are relatively simpler, but there can be many challenges. I mean, I give you an example, which we found, is that dental care, the differences between public and private in one medical scheme is literally, 100 in the private sector and 1,200 in the private, 100 in the public and 1,200 in the private. Even in terms of spend on hospitals, in a fairly strongly capitated, managed, controlled private medical scheme, the difference between hospital expenditure was literally an order of 5 times bigger. But there's a sweet spot in the work that we've done in Soweto, and we'll share that at some point in the future, around a package of services that is built around what is a clinic with a doctor, with very, very much the services that can be currently provided by GPs, nurses, pharmacists, and current public service clinic that we define as the current PHC package plus a doctor, and that we've looked at and said that's a very doable package of services. And in fact, in some of the costing is very, very much possible within the private sector, envelope of cost. So I think there's work being done in that space. I think the other thing that has been looked at is the question of, can one find subsets? And the problem is, in capitation spending, it's per capita, it's per person. And there's some thoughts around, let's pay for only HIV, or let's pay for diabetes only, as a sort of gradualist approach. The problem is that with those sorts of payment system packages, you are invariably going to have to do that on a fee-for-service basis. You can come with less than a whole person or whole package, like we've just said, with, let's say, under 6s or pregnant women or over 65s. But you're going to find that people are going to complain a lot. It might be a way to go forward, but I think you're going to have great challenges like we had in 1994, where people want comprehensive cover for everybody. But that might be a way to start. I think the challenge with increasing the package, with everybody's touting the multidisciplinary team and suggests that everybody is included, means the audiologist and the physio, etc., etc. These are very complex pricing systems and models that one has to really think out. So I really think that is not immediate. The package we've talked about is something you can actually define, start with, and it's a very important multidisciplinary team we're talking about, which is community health worker, nurses, and doctors that are providing care. And this could be easily available across South Africa. So I think if you start there and then look at building on top of that various packages, that's our, I'm speaking for my role in Joburg, trying to do something like this, that I think is doable, but trying to get the whole set is going to be a question. And the question you asked is the cost. Hope that answers you, Celeste. I'm not sure if others have a question. Yeah. Thanks. Prosper, great to see you. Yes, sorry, Celeste, you want to respond?
I just wanted to ask where it would be published when you do share it. Where would we find it? The benefits package?
Well, I think it is on the website. If you go through my website, you'll see this NHI sort of link or menu. Just look for it in Soweto. There's some information there, but I will provide more information as we proceed. I just need to make sure that we're okay to publish it, but I think it shouldn't be a problem. But I'll put it out there so that you can just check regularly. And I think if I may say, the package is essentially the current clinic norms and standards of clinic norms and standards with the addition of a doctor. That's essentially what we think would be workable, and the guidelines that guide them. It's a relatively simplistic approach, but it's possible because that's not different to what current private sector contracting of GPs involves.
Thank you
Thanks.
so much.
Hi, Prosper.
I appreciate it.
Good. Prosper, how are you? And welcome.
Thanks a lot, Shabir, for this wonderful presentation. I just have two small issues for clarification.
Yes.
One thing I have noted is that the NHI is going to shunt the provinces to deal more or less directly with the districts and sub-districts in terms of providing the funding. I don't know what has happened to or what is going to happen to the political and administrative structure that had emphasis and a lot of authority at provincial level. Is there similar kind of change going to take place to accommodate that so that there's harmony? The second issue is I was running through the bill, and one of the things that I saw was that NHI will not apply to, I think, to the military or to defense. And I was wondering, since this is aimed at boosting or helping achieving UHC, why not actually cover all the population rather than segmenting taking out the military? Possibly there is a particular special attention that is required for those people. Over to you, thanks.
Yes, I think that in terms of military, just taking the first question, I think military is always something sensitive, and I imagine, I don't think we've got an enormous military membership that would be big, but I think that, is something that would have to be, I think it's just politically sensitive. I don't know that there's going to be that much of inequity. There is certainly a very privileged system within the medical, the defense system, but I'm not sure exactly how that compares to the public service at the moment. I think the question you asked regarding the sort of rationalization, I imagine that because we have these provinces or these districts now accountable to the National Department of Health, that the role of the role of staff within the provinces will be turned down to be more related to the coordination and support of districts. But I imagine that all the staff will, or some of the staff will be transferred through to national. I see that somewhere in a document that suggests that it may be that the staff, and I think, remember that the current staff, so for example, I am employed in Johannesburg Health District, but my employer is the Gauteng Department of Health. And what it seems is that all the districts staffing will now be employed by the National Department of Health. And so even though we are paid by Gauteng and by the district, we will be paid, our pay slip would potentially say National Department of Health. So it's creating a much more centralized system. Again, questions about whether that is going to work or not. I think that it may be that over time, the various boards overseeing institutions like a hospital or a district, depending on how it goes, may be empowered to make decisions or transition towards employing directly. But I think that is all lots of difficult questions right now. So I don't think we can easily answer it, but these are research questions. These are questions we could be asking as researchers. What would be the best way to manage staff and manage this transition, and where would we be optimally in terms of rationalizing various structures? But I think this will be an evolving process, but very much informed by research. So plenty of research questions, as you can see, in terms of the bill. So it doesn't, I mean, I don't think that it's fair to say it must answer every question out there, because it's a piece of it's a brick in a very important foundation, but it's not the whole house. That does take time to build. And all of us doing good research in that space will be very important. Any more questions and comments? Thanks, Prosper. Any more questions and comments? I think there are any hands up. I just want to announce that we will be looking at the next meeting, having Professor Steve Reed to in fact talk about COPC principles and the challenges with the NHI implementation. So to say, to bring these two together and try to think through all these issues. And I think we are not just about COPC, we are about both these animals and all that happens in between. But we are focused on primary health care in this environment and would like to have much more focus on this. So you're welcome to, in fact, offer yourself if you think you can provide some very valuable input. So please reach out to me, Shabir@profmoosa.com. You can also, if you're interested in joining the research group, feel free to go to the NHI tab on profmoosa.com, and you can indicate your willingness to join either this to be regularly informed of, or to join the research group, which is closed and happens after our meeting now. So any more questions? If there are none, thank you all very much for joining us. Steve, yes, Steve's going to talk more. Steve, go ahead, maybe a little taster.
Yeah, just an intro for next time. I want to address the gap between the legislation and the practice on the ground. So if you find some of these concepts confusing, what I want to do is to make them as practical as possible from a primary healthcare point of view. What do they mean? What if we're looking from the ground up? You've been presenting, as it were, from the top down, from the legislation, what's in the, but there are huge gaps, and looking at that gap is where we need to focus as researchers. We need to ask the right questions. What is in this black box? How do we reach this idea of universal health coverage? How does the NHI contribute to that? But from our perspective in primary healthcare, how do we plan proactively to reach the people who most need the care? So that's for next time.
Great. Thank you very much, Steve, for taking that up. And as I say, if you have any thoughts or would like to share in terms of these series, feel free, of other speakers you feel could be very strong contributors. I'm not sure that I should ask Prosper as well, maybe to share, but we'll be in touch. Thank you all very much for joining us.
Thank you. Thank you.
Thank you. Take care, everyone. Bye-bye now.
Bye-bye.
Have a great day.
Thank you.
Bye.
Thank you so much. Thank you, Prof. Moosa, Prof. Mustafa. Thank you.
ما انتهت لكن ما قفلها من هنا.
The meeting is over. I think the meeting is over.
عشان الواحد ما